Thank you, Sachin. We now have 20 minutes for discussion. We can either take questions from the audience or from the web. While you're assembling your thoughts, I'll pick up on a point that Sachin made at the end about reminding us how expensive it can be to go back and retrofit data to share it. And the first few speakers spoke to the issues of standards. So just a question to the panel. I mean, it's clear to anybody who's ever tried to do this that in retrospect they wish things had been standardized, but it's always wishing somebody had done it 5 years ago. So how do you, I mean, it's not an exotic topic, so how do you convince people, is it in monetary terms or some other way to convince people that they really need to think about striking the right balance of standards versus what they view as standards being a stifle to innovation? Welcome any and all to speak up.
I think all you have to do is look at asynchronous emails and realize that even with standardized English, it takes 4 or 5 emails back and forth to figure out what time you're going to meet. The standards process anticipates the ambiguity of human communication. We often trip over ourselves because we add complexity to the process, but we also improve the output of that communication. And I think that in itself is the best argument for the process.
Becky?
I talked to Paul Harris, who helped start an EDC tool called RedCap, and people love it because they can do whatever they want with it. And I think that investigators don't want to have their creativity inhibited. And he said, but when they get done entering the data, then they want to find it again and get it back out. They don't realize they're asking for standards. And you can actually put the standards in behind the scenes. They don't have to know that's how you're collecting male and female. And I don't think people realize that. So some more stories like your envelope letter would probably work well.
Thanks. Take some questions from the room.
Hi, I was thinking of Dr. Ioannidis' comment that, or his caution that if only some participant level data are released, there'll be a different form of selection bias. And I'm wondering, A, if what other people think of that, and also if we agree it's a concern, if when companies start to make initial steps into releasing data, if they would consider doing it, I guess the way Medtronic did with the Infuse data, say that you'll make all the data from a certain product available, so at least we have a sense that it's not just select studies.
I think that applies to everybody, not just companies.
It's just that companies are the ones that usually have multiple trials on the same topic. But.
Comments? Sachin, you want to?
Yeah, I think that this is a new field. I think the Medtronic announcement was, I think, really a first of its kind sort of leadership effort. And so, there's a lot to learn from that. And I think we're going to take a very close look at the work that they did at Yale in collaboration with Medtronic, and I think try to glean some of the best practices from that and join them, frankly.
Yeah, I mean, I can say, Deborah, we've been working on trying to do something similar to Merck for about the last 4 or 5 years, and Harlan mentioned it this morning. The word all is a difficult concept, so if you tell me, so I want all of the data on a project that's been studied for the last 15 years, the complexity, as you go back in time, the complexity becomes more and more difficult. If you told me I was going to release all from January 1st, 2013 on, I'd say that's a relatively simple exercise. So it does, the context is important, but it is absolutely the same question. I agree completely, which is one of the reasons why Lynn posed that question at the beginning. Yes.
Yeah, I'm Andrew Vickers. I'm actually speaking tomorrow, so I might steal my own thunder here. But I just feel I have to say this because it's come up over and over and over again. How difficult, time-consuming, expensive, what a total headache it is to share data. I've published numerous data sets on the web. Many of them took fewer than 5 minutes to convert from the data set I analyzed as a statistician. I'm writing up the paper and I thought, oh, hang on, I better share the data set. The latest one we did was 9,000 patients in 4 institutions, huge observational data set. It took 8 hours to do the whole thing, mainly because we had to rewrite all the programming code, which we also put on the web, in order for people to it's complicated, but all that code had to be rewritten. So for the actual data, I can't imagine it would have taken more than an hour to do that. Now, the reason is, if we'd shared all of the data that was available on those 9,000 patients, that would have been a multi-year project. We shared all the data that was needed to on all the data, you know, on what we published, and we published like 6 or 7 papers on, you know, the patients, what type of tumors they had, and when they recurred, and who their surgeons were, and whether the surgeon made a difference, and so on and so forth. And we've got to make a distinction. I think you can do 90% of the work in data sharing with pretty trivial investment of resources. The last 10%, to get all the data that you need, and sometimes that's important. I mean, if you're looking at a drug and you've got to go and look at all the adverse events, and you know, and that can often be very important, and that is going to take a long time and perhaps millions of dollars. But I do not, you know, I really have to stand. What's the right way of saying this? I really don't want people to leave this room with the impression that in general sharing data, or especially sharing clinical trial data, is incredibly expensive, because you can do an enormous amount of sharing, an enormous amount of work for absolutely trivial cost.
So you're saying, if I understand, selectivity and focus, if we use the 80-20 rule, basically, we can
It's
make our lives
more than
work.
that. It's like 90% can be done for 1% of the work.
Any comments from the panel? We look forward to your solution.
My only question back is, just in light of Dr. Krumholtz's comments about sort of suspicion about industry, what's to say that, you know, the 90% that you're saying that one should publish is the right 90%, and the sort of questions that emerge around what's contained in the remaining 10%, I think would, you know, I think raise confusion or questions for anyone consuming that data. That's just a question.
Like I said, the 90% is not always going to be enough, but very, very often it will be. I don't want the fact that the last 10% is so time-consuming and difficult to make us think like, oh, it's going to be such a hassle to share the first 90%.
Okay. Yes.
Yes, I'd like to go back to Dr. Fitzmartin's talk, and his comment that it's taken a while for people to even understand and embrace CDISC standards, and your surprise at the slow rate of uptake. If I follow you correctly, by a certain time, at least for industry-sponsored trials in certain areas, there will be enforceable common data standards, which I don't believe I'm hearing any resistance from industry. So I'm assuming there, but it's interesting in my new life outside of going back to the NIH, as I sit and hear council discuss the theme of standardization, immediately people say, oh, well, you're going to impose all this rigidity on us, you're going to stifle innovation. You've all mentioned that, and you sort of dismiss it as an issue, but it's not. In the academic community, the uptake, the ability to get people on board to really agree on common data elements in clinical trials funded by the NIH is still a huge hurdle. So I'm just wondering what the group thinks are proper incentives or processes to facilitate that, because our longitudinal ability to assess what we are really learning from years of studies invested, my area happens to be things like, you know, depression, schizophrenia, and all that, and Alzheimer's even, to learn from that cumulatively is incredibly frustrating. And we are all saying it's a simple thing technically to address, yet that simple requirement of just saying that there be agreed upon in the community, as someone indicated, they're not right or wrong, but to get that alignment still seems to be a huge hurdle. So I'm just wondering what people think it would take to get more alignment, that when review committees look at things, you have an element on there that says, are data standards being part of the study? That's not reviewed, that's not looked at, I can tell you, okay? So I just like to throw that out for discussion.
What you're saying is we need a benevolent queen. I couldn't agree more. She would just tell us what to do. When I was at NIH, I was a public health service officer, and yes, Lieutenant, you will do that. That's a simple solution. If you have 3 physicians in a room trying to decide on a data set, you have 4 very strong opinions. I think that consensus building, while the mantra of standards development doesn't always work if you want to be fast. It's more effective if you want to be agile, however.
Let me try and take that. I'm not the queen, but I might be the king. So I don't think it's as difficult. I mean, because I think at NIH we have the same issues. We fund a lot of research, and you can't compare things to each other because the data was collected differently. So now I think it's a maturation process that the investigators have to kind of hit the wall and realize, gee, I'm not getting anywhere unless I start combining data, and that may be a process that takes time for certain fields. But I can tell you at our institute, at the time of the Neurologic Institute, and we've invested considerable time and money in doing exactly what Charles said, is getting groups together, locking the door, and saying you don't come out until you all decide. And it's all very doable. So we have common data elements now for about 11 different neurological diseases. Our problem now is we can't get traction with the people at the front table to try and move them forward. I think there's a lot of interaction that could occur between the academics once you get to a community that realizes they really do need to come up with consensus common data elements. I think it's all very doable. And then how do you move that into CDISC or HLA7? I think that's the question I have. So we've been working with CDISC on Parkinson's for a couple of years, but we have 11 others. We just haven't been able to get any movement.
At NIAID, they developed data sets for HIV. The data sets were incompatible with TB and malaria, the 2 most common comorbid diseases. I think that goes a long way in describing even the intramural issues about agreement amongst the investigators. I think at some point a higher level initiative has to say enough is enough.
I will say that when we talk about CDASH, that is completely harmonized with the case report form standards that are analogous to that at the National Cancer Institute. But now, like what you said, a lot of the NIH centers are doing their own therapeutic area ones, and I have to say that Lynn's actually started a standards effort at NIH going to happen on the 19th of November to bring some of that together and see what we can do about it.
It's a great discussion. Next.
I'd like to broaden the discussion of patient privacy in at least 2 ways. One is, even if the medical research enterprise is doing its best to meet privacy standards, the question that the Time magazine article that was cited raises for me is, will it be able to withstand the onslaught of big data and business analytics? A celebrated recent case is that Target often knows about pregnant daughters before their parents do. Another example would be with our smartphones and our geographic location being easily tracked. To deduce somebody is at a physical therapy center for physical therapy or at a dialysis center for dialysis doesn't require a whole lot of analytical brain power. So there are commercial interests that are using lots of different data sets in ways that, in my mind, can completely undo all the good effort that went with HIPAA, and there are more non-covered entities than covered entities. Those restrictions are in a pretty narrow space. So the question is, can we withstand, can our best efforts on privacy withstand what's happening in the general commercial space? And the next is a kind of sympathetic observation that as people's prognosis gets bleaker, their valuation of privacy declines pretty predictably against other objectives, like some kind of therapy. And we don't seem to have given much attention to how to move with them, as opposed to try to set a universal standard that would be applicable to all. So any comments on either of those would be interesting.
I just want to echo your second comment. I'll put on my clinician hat for a second, and you just show me a sick person who's like really worried about their privacy or security. They mostly care about getting the right care at the right place at the right time, and they want their information to flow to the point of care. And so I think our weighting of patients in the sort of discourse around privacy and security often overweighs certain voices as compared to the sort of silent majority of folks who are actually really, I think, desperate to need care. So I just want to echo that sentiment. I thought that was great.
Yeah, I mean, I think that came up in a Learning Health Systems symposium that took place earlier this year. The number of participated in. The gentleman who was in charge of HIT for NHS said exactly the same thing. He said that the concern about privacy among patients is not necessarily well represented in the discussion. It's mostly a discussion among the lawyers. So, Mike.
Yeah, I too was impressed by the expense that Rick Kuntz mentioned, $2.5 million to take one data set and de-identify it and put it in a form that others could interrogate without breaking privacy. And most of us, I think, have been speaking from the point of view of ongoing institutions. And having recently left academia and thinking about some of the clinical trials I participated in, I'm trying to imagine now if somebody came to me and asked for data from 3 years ago when I left, and I had to come up, if it wasn't 2.5 million, but still a fair amount of money on an NIH grant that closed with no money left. I'm just, is there an allowance for that? Does anybody currently have a mechanism? So, because we've been talking about academia and industry participating equally in this, and I think the spirit around the room is that that's what people want. But there's a big financial implication if you're a single investigator working off a grant. I just don't know how you can make this work?
No, that's one of the questions that the group came up with that Lynn posed in the beginning is there's a practical aspect about the financial implications of a lot of money went into doing the initial research. Now the data is there. Somebody wants to use it again. How does that get funded? How's the resource? Even if you're able to do it with smaller efforts with 90% of the data, as was suggested, it's still not zero. So,
yeah. Okay.
So I don't know if any of I mean, it's clear. This group would tell you if you had collected the information in a standard way, it would be less expensive, but it's still not going to be zero.
Right.
Right.
Okay.
Steve Weitzman, Med Data Foundation. Hello. Can anyone hear me? I was a fellow of the Food and Drug Law Institute back in 1968-69, and 10 major companies paid for my fellowship. And we're learning about sharing again. I've had 43 years, well, they'll find out if it was a mistake or not soon, 43 years in the industry. And I've watched the evolution that you put on that chart of the old model and the new model. This is amazing to me that the industry has finally come to the point that we've got to collaborate, we've got to cooperate with each other, we've got to share common stuff, but we've been doing it in the pharmaceutical industry for years. Rebecca, and how many hours went into HL7 and C-Disc? Charles, does anyone appreciate that? Richard Platt. Richard works so many hours a day that his hourly pay is really about $10 an hour. He's on every committee and everything, and so many of you are there. There's no appreciation on the Hill of what's being contributed and what's going to be contributed. Sure, there have been some things now that have been publicized with 4 drug companies coming together and giving a database, and now 10 drug companies coming together. And in medical records, which we're also in parallel concerned with, we've got the CCC group, Mayo, Intermountain, they're here, Cleveland Clinic, Kaiser. I mean, we're getting ready to share. And I'm just so happy that the zeitgeist has changed. But going to one of Michael's points, how are we going to pay for this? We are living in an era, once again, of limited resources. I go to speeches of Dr. Collins, and he's scared because 80% of his budget's committed, and if they rip it out on a percentage basis, he can't do any new projects. And he's got to take people off. So in addition to this, I think this is a selling point on the Hill that we all should take advantage, because this industry, academia, are making their contribution. We haven't put it in terms of dollars and cents, but it's got to be immense. And we got to say to those people in the budget process, look what we're doing. And you've got to come up, and you can't cut NIH. And that's my point. The question is, how else are we going to sustain this if we don't cooperate?
Thank you. We have time for about one more question. We're running a little over.
Where does the role of the academic enterprise enter into the challenge of standardization and transparency? One thinks of the same conversation could have taken place within a large-scale, complex academic enterprise with everybody wringing their hands about the fact that everybody's sitting in their own database. They don't talk to each other. They're not accessible. They've all got their own health data systems and servers in their closets. And so it strikes me that in this cultural revolution that we are proposing here, in a way, there's got to be a responsibility put on the research leadership of the academic enterprise to create a culture in which there is a support for the standardization and exchange and openness that you're talking about.
I mean, I'll let Chuck and Becky know quite a bit about that. Certainly NCI and NIH are promoted a lot of work in the CDISC environment and try and push that to the research community. Whether they're allowed to mandate it or not is a different question. So it's a good point. And I know I know the acronyms changed through what was the CTSA process. There was a lot of promotion of standards, particularly from the bench to bedside initiative. So it's been attempted, but I absolutely accept your point. There needs to be more effort there, and I know Chuck and Becky can.
I just have a quick comment. 30 years ago, Kaiser Health was a mediocre delivery system, but they made a commitment to health information, and it powered a revolution in the organization. And despite all the people from Harvard or Hopkins, I believe that Kaiser has better data on outcomes, preventive medicine, readmission, diabetic control, and they've done it all by reducing costs and improving quality. And I don't know a better example. It's about time we learn from it.
I'd just say it probably depends on the institution, and I'm looking at the people from Duke in the front row, and you all heard from Rob earlier, and Bob and Meredith, they're here, and they built standards into their NIH roadmap grants almost 10 years ago. And I think that's an opportunity. I also heard some NINDS people at a data sharing conference that they pulled together say, we're not going to fund these studies unless you give us data we can use. So I think it takes some sort of a commitment on their part to do that.
Okay, thank you, Becky. One more comment before we go to our break.
Comment before the $2.5 million is used as a standard when we get out of here. I just want to clarify a few things. That was the entire budget, including systematic reviews for about a year and a half of work. And actually Yale's under budget, so that's actually pretty good. That doesn't diminish the notion about the data, but I think we probably had the most complicated chore because we were actually looking at studies that went back to 1997, paper case report forms, very complicated, 13 different trials. So it really is, I think, an outlier example of how complicated it would be to de-identify. And I don't want that to be, I want to make sure we understand it is expensive. There's no question about that. But it wasn't $2.5 million just to de-identify.
Well, thanks to our speakers. A fabulous discussion. Great questions. So thank you.